Welcome to the OrthoEd segment. Again, we're joined with Dr. Jeff Hall, the founder of OrthoEd and educator there. And we're talking about me and my case. We've done 2 episodes, one on the diagnosis, one on the risks or the brief risks. And today we're going to talk actually about what we might do with my ClinCheck. What are the next steps you might ask your aligner company to do to get the result that we're looking for. So welcome again to the OrthoEd segment, Jeff Hall.
Thanks, David.
So we talked a bit about this in the diagnosis. I have a space issue, but class 1 canine and molar, that's actually can be a challenging case. And therefore, we're thinking we might be removing 3-2 to allow us space, lower risks of recession on my lower teeth. Do you want to take it from there, Jeff?
Yeah, I think we've made the decision of removal of the 3-2. So the ClinCheck's come back, and what would I be looking at? The first thing is what everybody does, and probably what most people only do, is look at the final result.
Yeah.
And we're going to look at that and say, hey, is that a good result or not? Okay, would that be acceptable? So that would be our first part, and that doesn't look too bad. So that doesn't look too bad. So now, but the next part, which people don't do, is 1, we're going to look at the staging of the movements, and then 2, we want to look at the attachments.
In that order, is that right?
Yeah, basically yes. So we move this across step by step, and this is really good. What David's done here by gaining space mesial and distal to that tooth is now going to give better encapsulation of the aligner for that tooth to move. Now, I would have done probably the same on that canine as well.
Good.
So I would have done the same on the canine. And we use so you've actually done that, and you've actually started to do that. And we use a term called gable bends. So what we would have done is we would have added 7.5 degrees of distal crown tip or mesial root tip on both those teeth, because otherwise you've got an orthodontic force once again on the crown, which is going to tip those teeth. So that would have been one part that we would be changing.
So we're trying to limit our tipping. We want to get torque. We want to get root movement.
We want to get more root movement.
That's a good tip.
We want to limit the tipping of the crowns, and we want more root movement. So when I look at that, and now because we've done it this way, I would be thinking, and I'm sure that's the case, there'll be far less expansion required on the lower arch because you don't need to get the space. You don't need to get as much space. You may end up with a little bit of a black triangle. And we resolve that later on. Once again, it comes back to the previous podcast that we talked about, where you could end up telling your patient that they might need some composite build-up. It's a sort of get out of jail clause. So I'd be looking at your movements, and so let's look at the upper arch as well. So I'd be looking at it, and you can see the difference in aligners that you've got in the upper arch compared to the lower arch. And I would be ensuring that we've got passive aligners here, because otherwise you would end up with a situation where the upper aligners are going to break, and you're going to so I'd be making sure that I've got passive aligners that would continue at the same time. So
your patient wants a fresh aligner if they can have one, obviously.
Exactly right. Absolutely, because there's no extra cost for it.
Can I ask something quickly about, so we're removing the tooth, we've got a slight crossbite with the canine maybe. Is there going to be any issue with that?
Well, I think once you remove that tooth, that's going to make it much easier. So once you get to that state, and by removing that tooth, now I wouldn't be moving that upper left lateral part of the staging until we bring the canine in a bit.
Oh, yes. Yeah, okay.
Because otherwise you theoretically got a bit of occlusal interference as you move that across. And you'd say to me, but you've got the aligners in, Jeff. But that's all great until they're eating and them out. And so then you would end up with more of the occlusal interference. So I would be delaying the movement of this lateral. Considering you've got 37 lower aligners, you can slow down the movement of the upper as well.
That's good.
So
let's talk. Go on. Sorry.
Go on.
I was going to say, let's talk a bit about the attachments you might choose.
That's exactly what
good.
So when I look at the lower arch, just to start off with, Okay, I'm just going to look at the lower arch because this could be an hour conversation.
Exactly.
The first thing, so you've got a 3mm rectangular attachment here. I would like to have at least a 4mm. The bigger the attachment, the better. Now, on your canine here, these are the optimized attachments that Invisalign like to put on. Your active surface is only here and here. Now, if when you put your attachments on and you take away 1/10 of a millimeter, you've lost your active surface. So I personally think these optimized attachments are just a marketing ploy. And if you speak to the people with knowledge, they will all say the same thing. So I would remove that and put another long rectangular attachment on. Okay? So these attachments I think are useless. I really do. Okay? Some people like them. So now I can't find where the lower table is.
Just click lower left. It says upper or lower. There's 2 little checkpoints just there. Yep. Click. Yep.
Right. Okay. So here we are. So here we are, where we've got intrusion of all of these anterior teeth. So what you need is a horizontal attachment posteriorly to act as an anchor to support the reciprocal side effects. So without that, you ain't going to get you're not going to get the intrusion. But I'm going to ask you this question straight away. Why do you want intrusion? Because you've got a minimal overbite. So what they've done is they plan intrusion of all your lower anterior teeth, and then they're planning extrusion of your uppers. If you eliminated most of that intrusion, you probably don't need to extrude your uppers. Now you've got a far more predictable result. That's just to start off with. Okay?
That's a great point. So thinking about the reciprocal, like what we're doing to the bottom arch means we have to do something to the top arch, vice versa, and perhaps that's actually can be netted out. Yeah, that's fantastic.
Like your 3-3, for example, got 6.6 millimeters of extrusion. What part of your attachment, because this is your active surface, what part is pushing on that tooth to extrude it?
Nothing.
So you would have what we would do is a sash attachment, which is an angled horizontal attachment. Because you've done our module 4.
That's right. I learned that in the aligner course with you, and that's something I might even do a whole segment on that and other attachments that I've learned through your courses, because it's a really interesting one that has that 2 factors, the 2 vectors of force.
Yeah.
It's great.
So there's lots of things that I would actually change here, honestly. Your 3-6 some intrusion. See, I wouldn't have a problem doing a little bit of posterior intrusion for you because you've got a minimal overbite. So that wouldn't worry me to do. And you're going to get some intrusion anyway with the 2 pieces of plastic, and then you're going to get some rotation of your mandible forward. So I don't have a problem with that at all. But I think, the keys to what I'm looking at is obviously the final position, making sure everything looks good. That's what everybody looks at. But more importantly is the staging of the treatment and then the attachments. You've done a really good job, David, with how you've staged that lower incisor. And you could ask them for a pontic there. But once again, I see how when you've got the pontic, how you're touching the distal surface of that tooth. So I would be saying to them, with the pontic, if you're going to use a pontic, make sure you keep the surface of the teeth totally free so that the aligner can encapsulate the surface.
Exactly, that's the goal. Well, Jeff, that one little bit that I added to this, I haven't done anything about attachments or anything else, is because I actually learned it in your course. So thanks. That's the point of this segment as well, because I am obviously doing the mini masters. I look forward to everything else I learn. I hope that gives some people a little bit of thought process. Think about final result, then staging, then attachments. All are crucial. Thanks, Dr. Jeff Hall, so much for your time.
David, thank you, and I hope that I can impart some knowledge into the young dentists and just open their eyes, because one of my pet peeves, and I hate to say this, if you're not modifying this, there's no reason why you should be doing aligner therapy and not Smile Club Direct, because that's what they do. They just hit the button, they press approve, This is the thought process.
Exactly.
And after being involved in thousands of cases, I can tell you there's not one case that we haven't gone back with at least 2 or 3 times.
Absolutely. This is where we earn our money in aligners. The functional action that we do, you know, anyone, well, not anyone, but like our therapists can do that. We can have our team help us.
That's right.
This is where we earn our money. This is fantastic. Thank you. Thank you so much, Jeff.
David, thank you very much.